Yeah. Good morning. We are a bit late, but only 2-3 minutes. So I invite the panelists to come to the chairs, but two of them are missing. Gérard, you are in. I will replace David, and we need Dr. Inigo Garcia, Petre Cala, Dr. Spence, Dr. Barton, and Dr. Wu. Please. Good. We are missing some chair. We have only two chairmen. Can you replace David Dick-Smith? Thank you. We need one panelist. Maybe Yoshi, you can. You please come. We have to improvise because we had some missing people. Thank you. So in 2 minutes we'll begin.
Yeah, he's scared. He's scared.
From Malaga, but it's early morning for them, no? Dr. Barton, Dr. Spence. Okay, Manuel. Please welcome us in this for the third time in Spain, 2 times in Barcelona, 1 time in Valencia.
Third time. Thank you, Yves. Good morning, everybody. It's for me a pleasure to welcome you to Spain. And first of all, I have to apologize for the current political situation in our country, with a lot of problems to arrive to Barcelona, with a lot of cancellations. But as David said in Rome, EBC is a non-political, independent and informal club. So our mission is to discuss problems in bifurcation lesion. So in this meeting, we will continue in discussing problems in bifurcation lesion like in the last meeting in Brussels. The program is very attractive. In this meeting, we have a lot of topics for discussion: drug-eluting balloon, new devices, lot of news, and of course the left main incision, as always, at the end of the meeting. In the map, you can see the previous EBC meeting. This is the 15th meeting. And you can see that in Spain we have a record of EBC meeting. We have 3 meetings in Spain. 20% of the meeting were held in Spain, and the first meeting was in Valencia. In Valencia was my favorite meeting because we honored to my friend Alfonso Medina. Here you can see young Yves. Giving a present from the EBC to Alfonso because of his contribution with the classification to the EBC. A similar picture with Mariluz. Mariluz is the head of Abbott in Spain, also very young, and Alfonso very happy to be in the club. These countries contribute with lot of papers, lot of work in bifurcation, and always support the ABC. As you can see, a lot of paper, lot of presentation along these 15 years, the classification, a lot of discussion about the design of the stent to be implanted in the bifurcation, the technique, the kissing or no kissing, the gelling wire technique, the tips and tricks, the description of some sign as the eyebrow sign also by Alfonso, and more recently the importance of the gelled wire, the feasibility and the use of the gelled wire that will be presented in the same meeting, and finally the bioabsorbable vascular scaffold in bifurcation lesion, or the possibility or the study of bifurcation in combination with CTO that was also presented in the last meeting. So all these contributions are in the consensus of the EBC. As you can see, the production, the scientific production is big, is large, and is increasing and increasing every year. We have 9 consensus summarizing the EBC meetings, consensus about OCT, about left main disease, about the use of IBUS, about the use of bench stenting, consensus document also in quantitative angiography methods, the classification, of course, of the treatment and in the anatomy of the bifurcation, randomized study, and much more that I can't remember. So we can summarize our activity with this sentence of Patrick, that our papers and opinions are being heard in meetings around the world, in classroom and with the industry, and we are proud of what we have accomplished. In Valencia, the simile that I put for something exciting, like the meeting, was this bullfighting performance, but today is not politically correct, so I have to put the football match between Madrid and Barcelona to describe to make a simile with the interesting program of the meeting. So thank you for coming and have a nice meeting.
Thank you very much, Manuel, for these souvenirs. So we'll begin the first news session. We have 3 this year because we have a lot of actuality. And the first presentation will be done by Niels Holm. This is an update from New Zealand bench testing. So John Ormiston, unfortunately, is not able to come, but we still have his mind is there with us.
To be here today, and thank you very much for the kind invitation. Quite impressive to see the Spanish contribution summed up in this way. You have definitely done a very well job here, so also a pleasure to be here. So I will probably need to start something here.
Okay.
It's probably there.
Yep.
Number 1. Thank you.
You okay?
I hope so. Let's see. So it's downloading. Okay, so actually, yesterday during the sessions, I actually took a decision just to slightly alter the topic from recap on the the final POT talks where we would have added a bit more detail from the studies we did together with John Ormiston. But I just realized during the sessions that there's a bit more perturning issue that we're working on also in the bench right now. It's the DK cross technique. It's grown extremely popular over the past years, but there are also still some pitfalls, and I want to this morning just focus on one particular issue here, the first crush. So you're all quite familiar with this, that after implanting the side branch stent, you do the cross with a balloon placed here from the distal main vessel to the proximal main vessel, and then we rewire the crossed side branch stent. In reality, it's not always that simple, because we look at the OCT findings that we have, for example, at this level here. We look at the cross stent. Well, it does have, a certain volume. And what can go wrong here? When we rewire, we might not end up here outside the stent. There could be options to end actually inside the stent. I borrowed this example here, also from a patient with a tight proximal LAD stenosis and then into the left main. And you can see after crush, the crush is really substantially incomplete. And the physician ended up rewiring in the true lumen and then did OCT and repositioned into the side branch coming from the side after additional crush. So what could be the implications if we have that situation where we think we did this, but we actually did this and have this malapose segment here? Well, if we continue and rewire in the true lumen, there are also some very special situations where we can advance the wire out here. That could make it even more complicated. But if we advance the wire here in the true lumen, as we've seen a couple of times now, well, if we then continue and do kissing balloon inflation, we just get this result. And then we're back where we started immediately after implanting the first stent. So now we implant a stent as we would normally do, and we have converted our procedure to a classic cross or a mini cross procedure. Then we need to rewire the two layers of struts here, and then we come back to why David Hildek-Smith, which should have been in the panel today, declared cross-stenting for dead here already in 2008. So we don't get the advantages of the DK technique if we do an incomplete crush. So just to quote him once again, he had quoted himself for this over again, there's nothing more likely to go wrong than a complicated bifurcation strategy undertaken as something of a novelty. So what we're doing now in the bench is that we produce these 3D printed phantoms based on CT scans from patients with coronary artery disease. And while I prefer to show you this next year, but I thought it was a bit more urgent after some cases we saw yesterday, this should have been running repeatedly. It did just before. Maybe I can press it again. Can you make this run again? Okay, but else what this shows is that also in this model here, maybe I can do it just from here. Oh, thank you. Maybe it does. Okay, so what this one shows is that in this patient-specific model where you have a proximal LAD stenosis, we are able to show that you also get this cross phenomenon, and then we can play around with the rewirings and the various scenarios that we get from there, and we will come back to you both with a publication and more demonstrations of that next year. So what we advise now based on this is that with the first crush, you use the same balloon as you probably do today. And in particular, in the left main setting where you have major differences, you repeat the crush with your pot balloon. You need to use that anyway later on. And I know some of you are already doing this, but I also realized that a lot of physicians don't do this routinely now. So please add this additional step. You should use this balloon anyway, but already at this time, make sure you have a very good cross, because then your rewiring is much more safe. So in conclusion, double crush in DK cross may lower the risk of suboptimal side branch rewiring. Use the pot balloon sized according to the proximal reference. Intravascular imaging is still required if you want to evaluate the wire position to completely rule out any suboptimal rewiring. And the clinical data, at least in the October trial that we're performing now, we should be able to provide you the incidence of these findings, the rate that by which they appear. So thank you very much.
Was not really a bench from New Zealand, but I think this is a technical point that is also raised now by Xiaoliang Chen himself.
Yes.
To avoid insufficient crushing of the stent. So I think it's a very important technical point. Some questions?
Another way to avoid this unfavorable rewiring and first kissing that we said it should be proximal. In the past, we said the first kissing should be proximal. Is what I proposed also yesterday, that I called it proximal side optimization. So when you implant the stent on side branch, then you pull back the same delivery balloon before to crash, and you inflate higher pressure. Then, if there is no compromise on main branch, you remove this delivery and you go there with bigger high pressure balloon. So this allows the most complete apposition of the stent inside branch ostium and allow you a wider space of optimal rewiring. And that's make more easy and independently from the angle between main branch and side branch, and also independent from the length of side branch in main branch, the protruding part.
So there's no doubt that also the plaque preparation of the ostium is really a major importance here in the DK cross technique, also to get the optimal result in the ostium to facilitate the rewiring subsequently.
So I think this is a kind of very important talk, especially for the beginners, because that the most do not know that the most dangerous procedure or the part is that the first recrossing, because all people believe that after one cross, the stents are completely crushed, especially the outer wall, but that never happens. So that when someone decide to do DK crush, that part should be reminded very importantly, and several balloon inflation with high pressure adequate size is essential. Right.
Thank you.
Let's comment of the first kissing balloon inflation. The kissing balloon inflation causes overlapping in the proximal side. But however, we cannot control the overlapping style. So you mentioned about the parallel type. However, the high angled bifurcation overlapping style changes to the X shape. So in such case, the crush site is more member cell or counter side, so not in the lateral side. So if you can control the crushing side to the lateral side, you are ideal condition. However, maybe you cannot control such thing.
It's very much directed by the plaque composition in the to where it crushes. So it's directed by the plaque opposite the side branch takeoff. So.
Okay, thank you, Dr. Holmes. For the sake of time, you have to go move on to the next talk. So we are going to learn about the BIOSS bench study from Dr. Derimay. Please.
Thank you for the presentation and the invitation to present this experimental data about the new dedicated stents, the BIOSS. And so what is the BIOSS? You can see a BIOSS implantation in a fractal bench. And as it's obvious to see, the specific design of this new DES takes already account two main elements for the bifurcation revascularization. Firstly, the physiological fractal geometry of the bifurcation with two differences of diameter between the proximal and the distal part of the stent. and secondly, the need to keep free the side branch ostium by only two big connectors in the POC in front of the side branch ostium. But facing this new design, many questions arise. Firstly, we wonder which scope for the BIOSS, in fact, which spontaneously scope for the BIOSS. Then we wonder about the real behavior of the diameter during the inflation, and also what could be the use of the BIOSS out of the scope. Then the classic question about the maximal overexpansion, and we also wonder about the side branch management. First question concerning the spontaneous scope of the BIOSS, and to answer this question, we compare the 7 designs offered by the company with all the association of diameter according to the Finet law in this table, and you clearly see that spontaneously the BIOSS fit only in 40% of the cases, but we will see that it's possible probably to increase this percentage. The second question concern the behavior of these two diameters, the proximal and the distal. And firstly, we analyze the inflation of a BIOSS without a bench at 18 atmosphere to quantify the overdilatation in the proximal and the distal part of the stent. And as you can see, the total overdilatation is pretty high, greater than 10%, even 15% in the distal part of the stent, largely greater than observed with the classic DS. So it seems that the balloon, the BIOSS balloon compliance is higher than the usual balloon of the DES. It's confirmed when we implant a BIOSS 3.5, 4.25 in a fractal bench with references at 3.3 and 4.1, because you see that the nominal diameter are reached at only 10 atmosphere, so lower than the classic DES. The second point in this experimentation is the evolution of the stepwise between proximal and distal diameter according to an increasing pressure. And you see that this stepwise is stable, so we observe an homothetic inflation and homothetic variation of the diameter during the inflation, which is a key point to implant a BIOSS. We also try to use the scope, the BIOSS out of the scope. So this time we implanted always in fractal bench 3.5 BIOSS with references at 3 and 4.1. And so, like the previous experimentation, the nominal was reached at low atmosphere, 12. And we tried to realize segmentary overexpansion of the proximal part at very high pressure, 26 atmosphere. And you can see that more or less it's impossible to realize this segmentary overexpansion because the stepwise, because the two diameter is or keep stable even at very high pressure. Oh, sorry. The next question was concerning the maximal overdilatation. The overdilatation is the proximal part of the stent, a key point when we want to treat the left main. And you can see that the overdilatation of the BIOSS is really high with a maximal diameter at 5.6 for the smaller stent and largely greater than 6 millimeter for the bigger stent. So this overdilatation is equal or even higher than the overdilatation observed with the DES. Obviously, this overdilatation is at the cost of proximal shortering, really significant, as you can see on the picture, and it seems necessary to keep in mind this shortering, especially knowing the specific design of this BIOSS. The last question was to understand and to try to improve the side branch management with the BIOSS, and so you can see a zoom of the POC, sorry, during a BIOSS inflation, and you can see 2 points. Firstly, a rotation of the stent around 70% and a small pullback just before the stent implantation. So it's easy knowing these 2 points that the position of the connector will be unpredictable, and also the management of the central marker should be difficult. That's why it seems possible to, unfortunately, finally position the big connector in front of the side branch, and we wonder that if it should be benefit to realize a systematic side branch opening. But as you can see, the connector is so big that even with a side branch inflation, you can push the connector, but it seems impossible to totally clean the ostium, so we are not sure that a systematic side branch inflation need to be done. The last point, to keep in mind, it's that the maximum length of the connector is 2.5 millimeter, and so it's an important point when you want to treat a bifurcation with a side branch greater than 2.5, because you will automatically position some strut in front of the side branch. So to summarize this experimentation, firstly, it shows that spontaneously the scope of the BIOSS is not very high, only 40% of the bifurcation. But the BIOSS owns a very compliant balloon with homothetic inflation without the possibility to realize another segmentary expansion. The BIOSS stent presents a very high post-dilatation capacity, equal or even higher than the classic DES. And concerning the side branch, it seems that the control of the connector position should be difficult, but we are not sure that a systematic side branch inflation needs to be done. So when we try to add this information to the initial table to better understand the scope of the BIOSS, it seems possible to add to the 40% knowing the compliance of the balloon any other bifurcation, and knowing the possibility to realize, it seems that the large majority of the bifurcation can be accessible to a BIOSS. Thank you.
Okay, so thanks for the excellent presentation. So any questions, comments from the floor and panel?
Of course, I think the shortening of the proximal part of the stent is a concern, but this stent is, has to be completed in majority of cases with a proximal stent, because this is not designed for all the left main have not the same length. So this problem can be corrected with the additional stent. But what is remarkable in this shortening, of course, is all the rings are very close together, so they may deliver more drug in this portion of the left main. And if you add this, another additional stent proximally, you have to do it side by side and probably not overlap.
It's one of the big, not big, but it's one of the issue of the stent, of course, because it's the extreme case. It was post-dilatation at 6.2, so maybe it's not the daily case, but it's sure that it's an issue, and in my mind, to add a second stent is not a good treatment for left main. So I think that if you want to put a BIOSS, it's because you want to make a simple revascularization, easy revascularization. So the procedure need to be easy. If you need to add a second stent, or if you need to realize a kissing or whatever, it's not easy. A pot, okay, is easy. A nice pot, not a pot at 6 millimeter. So I think that it's an extreme case, and I'm not sure that we need to do that and add a second stent, and we don't know really what we do. So it's just a test in extreme condition in this experimentation. But I'm not sure that to plan to put a BIOSS and to say, I know it will be short, but I know that I want to put a second stent. I'm not sure that it's really good. In my mind, I prefer to put a longer stent, a classic stent. It's not too bad. And after realize a perfect report, it will be perfect.
So what you say is that this is extreme dilatation. So in most clinical conditions, this is not occurring. This shortening, major shortening, is not occurring.
It's
in clinical condition, I mean, in
but
the normal left main 4.55.
Yeah, but the shortening is proportional to the over-dilatation. So if you post-dilate at 5, the shortening will be shorter.
Yeah, François, thank you for this important data. Did you check kissing versus no kissing after deployment of the BIOSS?
No, I'm waiting more stent to try this. I didn't check that, but I think that the key point with this stent is to know if the side branch, we need to open the side branch or not, by kissing or just by a classic stent. I'm not sure that the kissing is really a good is a good place for the side branch opening in this stent. But I'm not sure that we need to open the side branch, to be honest, because I can only test this twice, because it's really difficult to position the connector in front of the side branch according to the rotation. And when you want to push the connector with the balloon, it's almost impossible. If the connector is real in the middle, it's impossible to clean totally the side branch, kissing or not.
So there is a recommendation from Robert Gilles to do a dot systematically.
Right.
So do you think that it may push the carina toward the circ, or is it?
I think that it's this recommendation is probably due to the high compliance of the balloon. Maybe that means that we need to prepare really strong the lesion, because the balloon of the BIOSS is not the same as the usual balloon in a stent. So I'm not sure that the pot can improve or decrease, but improve the osteotomy.
No, I'm talking about dot distance optimization.
Sorry. It's the same. I think that it's the same. It's due to the compliance of the balloon also. So for me, the dot change anything in the side branch. But in you.
One small question. What about the gap between the two stents? I mean, the main vessel distal and the proximal. I saw also that there was, with the post-dilation, with POT, there was an increase in the gap. Is it true or not?
It's true, but it's due to the balloon. I'm not sure if I can. No, it's impossible. In the picture, you can see that, because when you inflate a big balloon at high pressure, you have an increase in diameter, but in length also. So it will be push. It will push a little the stent and in the connector and in the transition zone. So it will increase a little the transition zone. But I didn't quantify that.
One disadvantage of conventional stents across a bifurcation is that you move the carina, but this, because it has one connector at the carina, it may not move the angle so much. It may not change the angle between the proximal vessel and the distal vessel as much, because it's only got one connector. I wonder if you could comment on that, whether that might be an advantage, that it doesn't distort the anatomy as much as a conventional stent.
It's sure that if you decrease the metal if I well understand your question, I'm sorry, but if you decrease the quantity of metal in the POC, you will probably keep a more natural angle in your bifurcation. But the angle is very difficult to analyze in bench. It's impossible today. So I didn't try that, but I agree with you. It's probably a good point.
Thank you, François. And so you move to the next speaker, Nicolas Foin, and for learning from the bench and the thrombogenicity model.
So thank you very much for the invitation. So first, I wanted to start with learning from the bench. Why are we using the bench? And basically, bench models, they allow to study question in controlled and reproducible experimental environment. You can use tools that like micro-CT, radial longitudinal strands, 3D printed model, histology, SEM, microscopy. But we have to recognize also their limitation, that it's only a partial view and a partial model, and it cannot mimic the entire tissue plaque characteristic or the biological response. So it should be interpreted with caution, and bench models, they complement, but they do not replace, for example, clinical or imaging study. They cannot replace that. Through the EBC, I mean, my experience, we had a lot of learnings, and as you looked at stent recrossing or the impact of post-dilatation, various distal recrossing versus proximal recrossing, different experiment to test also side branch dilatation. Every year there is more question, and every year you iterate. That's a little bit the my EBC experience. So a lot of those ideas also came from this meeting. You can try with lesion model. We also looked at the impact of stent design on expansion. So I think this was also coming from this meeting, the realization that stent design is very important, and that not every size has the same expansion capacity. Also looking at what happened then to the coating of the stents when you overexpand, and looking at what happened to the radial force as well. So how do the stent react to those overexpansion in terms of stiffness and radial force. And we came up with those tables where we tested different size of stent and their expansion capacity, and this was the latest update, and we will probably need to re-update that based on new workers that are coming. Now, I wanted to spend time really to present a new model and new experiment that the team in Singapore has been working on, which is a thrombogenicity model. So we know that shear rate is an important concept, and it's basically measuring the gradient of velocity in the bloodstream. It's high in presence of flow disturbance, and it's a well-characterized modulator of platelet activation in thrombosis rheology studies. So you find those studies where they do increase shear rate, and you see the platelet activation is increasing in a dose-dependent manner. So from rheology studies, a very well-known trigger for platelet activation. Now, where do we find high shear rate? And you can see here those underexpanded stent CFD simulation and malapose stent. So there are two situations. When the stent is underexpanded, you see you have a jet, and then you have high shear in the middle of the vessel. And also when you have malapose strut, you have high shear, and the more the malapose strut hard, the more the highest shear and the highest shear area affected by it. And typically this is relevant in bifurcation because we find underexpanded stent at the proximal edge of the stent and also at the side branch ostium. So the question we had was, do those malapose struts affect platelet aggregation more than well-apose segment? The in vivo clinical evidence is not clear, at least not for DES. So we came up with a Chandler loop model where we perfuse porcine blood, and you see that we on purpose under-deployed a segment of the proximal segment of the stent, and then when we do that, we perfuse with blood, you see we only find clots in that malapose segment. So very, very interesting, and we quantified that both with histology and OCT. You see the results are very, very consistent. This was published, the method. So you really need that substrate for clots to adhere. And we tried the same also in a bifurcation model where the stent is well expanded, just there are struts left at the side branch. And you can see here the clots also only, I don't know if I can show. You see here, the clots only localize in the side branch strut here and here, but you don't find clots in the rest of the well-apposed segment. So it's pretty interesting because it's consistent that there is something happening there with the flow that activates those platelets, and that is not completely benign. If you try with the BRS, well, it's not really helping. And we find also clots in the side branch and a little bit more clots around the struts well apposed. And lastly, Valeria presented this abstract yesterday. We were interested, I'm glad, Niels, that you raised that point. So we were very interested in understanding also the difference between tap and decay crush. Having done some of those crush also in modeling with some physician helping, I also realized that this rewiring is pretty tricky already in the bench. So we always wonder how is it happening in vivo. But here we compared those two techniques in that bench model, and you see in terms of flow, the CFD showed that the share was pretty equivalent. You have those struts in front of the carina triggering flow disturbance. But when you analyze the clot formation, you see that there was the clots here formed at those malapose struts that are formed in front of the neocarina in both cases, and the difference was not statistically significant. So we see there was no difference in terms of strut apposition, similar acute formation. Also, a final pot could reduce the eccentricity index. And it's important that even in a perfect silicone model with everything controlled, you still have a lot of stent malapposition there right in front of the carina. And the question is then, how does that look with IVUS and OCT at follow-up? I haven't seen many images, so I think it's a good question. So in summary, we've seen that stent index expansion and malapposition distance affect flow disturbance and share rate in a dose-dependent relation. Severe malapposition create higher share with also persistent malapposition and uncovered strut at follow-up. In vitro experiment with perfused blood, they show that large malapose stent segment creates site for platelet adhesion and clot development. And this leads to stent optimization, both in terms of expansion and apposition, with appropriate sizing, appropriate post-dilatation, and imaging. It can improve the local hemodynamic environment and reduce those area of high shear disturbance. And so, of course, what we aim for is a perfectly embedded stent that will then reduce the risk of acute occlusion. And thanks. I hope we'll get the chance today to visit the city. And thank you for all the collaborators in Singapore and all the friends from EBC. Thank you.
Thank you, Nicolas. Thank you. I have just a question rapidly to satisfy my curiosity according to your excellent and very exciting model. And what's happened on your clot, not after the very short 4-minute blood perfusion, but after 10, 20, 1 hour. In other words, could you quantify the location of your clot or the amount of platelet adhesion in your model?
Yeah, so you're asking how did we quantify the clot in the model, right? Yeah, we quantified that with CD61 with histology, as well as with imaging, quantifying it with both. And it's very sensitive model, meaning like we treat the pig blood with anticoagulant treatment, but it's still very sensitive to share. In vivo, you would never see clot developing that fast because you have DAPT, the patient is on heparin, etc. What it tells you is that in the blood and in the platelet activation mechanism, when you have those struts left unapposed, they trigger a mechanism that favor clot development. That's the only thing we learn, and that's maybe more relevant clinically when you stop the APT and you still have a lot of malapose strut, then it's more like an explanatory mechanism on what could happen.
In terms of the stent gel strut, your data is very consistent with the clinical data and the follow-up
Exactly.
OCT. So we reported the follow-up OCT. On the gel strut, thrombus attachment more frequently, 30% versus 1.1 or 2% in the final Kiss-Barron inflation group. However, we also found the remained gel strut, miserably distorted remained gel strut, has more thrombus attachment at the surface of the gel strut. How do you recommend the final Kiss-Barron inflation or not, according to your study?
Well, you know, we're presenting those, that something is happening when you leave a lot of struts, and it's dependent on the distance and the amount of struts. So one strut close to the wall doesn't matter. Now, what is the clinical implication? This all comes from clinical data. This is just like one block, and I cannot make a recommendation based on that model.
Thierry?
Yeah, thank you very much. I think these data are very important, and we had some confirmation from Dr. Murasato. I was wondering if you have done the same work, because you were comparing TAP and decay crush. But did you look at just a simple stent crossover without opening the strut to a kissing balloon and to a T, not a TAP, but a simple T? So maybe you have very important differences in terms of thrombus.
Yeah, I showed the one where you had still the strut left in the lumen. If you optimize the strut and it's completely opposed, of course, then you don't get those clots accumulating. Did we? I don't think we did a very systematic comparison of optimization versus not optimization, but that could be something. I mean, of course, you would see then that if you don't have those strut left hanging, the clots are not there, but I don't think we've done it and published it yet.
Thank you.
Not that way.
We are late, so we move to the next speaker. Gabor Toth will present the bench again, a bench evaluation of the new REVA scaffold in bifurcations.
Thank you very much. In this talk, I would like to show you how far one can go with the phantom scaffold in non-complex bifurcations. You can see the disclosures. So we all know that the structural and mechanical capacity of any bioresorbable scaffold are considered to be inferior as compared to metallic stents. And accordingly, I also know that stents are exposed to major stretching, deformation, overstretching forces during bifurcation PCI, and therefore practically scaffolds are not recommended to be used for bifurcation lesions. But we have to also admit that there are cases when someone uses scaffold and it's unavoidable, or you need to have a bailout strategy for bifurcations when you decided to use a scaffold. In this study, we wanted to evaluate how far you can apply these aspects for the phantom latest generation bioresorbable scaffold, which is a copolymer of tyrosine analogs and hydroxy esters. It's considered to have high radiopacity, which allows proper positioning, somewhat thinner struts than as compared to other and previous generation scaffolds. The radial force is higher than the previous ones, almost metal-like, and the expansion capacity, as described, it's relatively high, reaching 15 to 20%. They say the aim of the study was to evaluate whether pot side pot technique can be considered as a reasonable kind of bailout option for the phantom scaffold when you have to tackle simple bifurcation lesions. Pot side pot, we also already discussed many times, and I just want to highlight again the steps of it, why we considered this technique and not something else, simply because by skipping that step of kissing, we might avoid massive overstretching of the stand platform. This is, let's say, this is probably the most gentle way to touch a bifurcation. This is why we consider this for the scaffold. So we use the rubber-like elasto material for the bench in a 35 to 39 degree water bath, and we used two different models. One for the smaller design stand. This was a 3530 2.36 degree angulated model. And for the larger scaffold, we used the 4135 to 760 degree angulated bench model. So the dilations during the whole procedure were strictly pressure and diameter chart guided. So in the 30 scaffold, we went in the proximal main branch up to 3.51 millimeter, 30, strictly 30 in the distal main branch, and we used 2.0, and we went even up to almost 2.4 millimeters in the side branch opening. For the larger one, here you can see the bench sizes, and here in the proximal main branch, we went just a bit above 4 millimeters, 3.5 in the distal main branch, and 2.5, 2.7 in the side branch opening. So we were very careful really to follow the pressure diameter chart and not to overexpand the scaffold as compared to the recommendation of the company. Here you can see the fluoroscopic imaging. Indeed, we can confirm that it's really a nicely radiopaque scaffold. Here, two blinded operators were asked to review all these images and try to identify whether there is any strand fracture can be identified or not. And in none of the images were stand fracture identified by the operator. So let's say we can assume that even in patients it might look like this, and angiographically or fluoroscopically there is no major scaffold damage seen. You can see the OCT analysis. With OCT prior the final pot, so just after side branch opening, and we did OCT after the final pot, and as expected, of course, there is a with the final pot, there is a marked increase in the good apposition and the decrease in the malapposition. So final pot is indeed needed, and as expected, there is nothing new. This malapposition difference after final pot, it's coming from the abosteal side of the bifurcation. This is where the side branch opening pulls the struts in, and the final pot, if performed properly, it can be corrected. So this can be also observed in this model. And what we have seen that there was a difference between the small model and the large model, more marked malapposition in the large model and the large stand, and here the region was the ostial side of the polygon of confluence, where in the larger model we could not reach as good apposition rates as in the smaller model, smaller bifurcations. The micro-CT confirmed that the scaffold has reached the diameters what we wanted to reach actually in all regions, and we also compared a kind of estimated recoil. So we compared to the diameter what we are supposed to reach with the balloon to the diameter what we have seen at the end by the micro CT imaging, and here we have seen that there was no difference in the proximal main branch in recoil between the small and the large model and the small and the large scaffold, but there was more recoil in the large model, in the large scaffold, in the distal main branch as compared to the smaller model. And now we come to the let's say the visual analysis of the micro-CT images. Here you can see all the 7 cases of the small model. Just to see why we have so many, we have the look from the left side, the look from the other side, look from above, look from below, just to really be able to understand strut deformation. And I would like to show this one. This is one of the 7 cases in the small models. There was one strut fracture. Note, this is not a connector fracture, this is a ring fracture, meaning that it's related to loss of radial force immediately with the ring fracture. I would like to say again, we did not overexpand these stents. We really used, as indicated, relatively small balloons for their side branch opening. Still, this fracture occurred. This was in the small model. And what we have seen in the large model, there were many more cases, so actually 4 out of the 7 cases where ring fracture was found, and there were such extreme cases as well where in the proximal main branch we have found all over ring and connector fractures. Again, I would like to emphasize we did not over-dilate this scaffolds. We remained within the recommended range of dilation. What we just added is this side branch opening, again, with relatively small balloons, not going over 2.7 millimeter to opening the side branch. Still, it caused major strut fractures. So what we concluded from these findings that although this new device is considered to have improved structural characteristics as compared to previous generations and previous scaffolds, still there was marked structural destruction of the architecture of the stand, even when we were just doing nothing more extreme but a pot side pot technique. And considering that pot side pot technique is probably really the most gentle way to touch a bifurcation, comparing these two findings, we can say that there is we would strongly discourage the use of this scaffold in any kind of bifurcation, simply by the high risk of stent fracture and completely losing the stent architecture, even during a kind of gentle procedure. Thank you very much.
One question.
Thank you, Dr. Toth. In your protocol, do you use a long and step-by-step inflation to respect the viscoplasticity of polymeric stent, or in order to, because metallic stent are elastoplastic and polymeric, unfortunately, are viscoelastic, and the time of the stress play a pivotal role to avoid a fracture. And so I would like just if you apply this protocol. Like
very good comment, and it's very important comment. Importantly, for phantom scaffold, slow inflation is not recommended. For phantom scaffold, what the company says that the pace of inflation is just like with metallic stent. Still, we were more on the careful side, so we went slowly, but definitely not as slow as it was recommended for absorb, because for this device, it's not needed. So what they claim that it's not needed to go very, very slowly. So theoretically, you could go just like with metallic stent. Here in the models, we were more on the careful side, so we went with slow inflation, and still, this is what happened.
And this recommendation is induced by which criteria? Just a slide and lock design, or a new design specific to inflate rapidly? Because the polymeric stent is always a polymeric stent, and so the mechanical properties are the same, and the limitations are also the same.
So I'm not an engineer, so I cannot explain where it comes from, but what I can say that it's said by the company that here, as compared to, for instance, absorb, no, you don't need to go slowly, you can just inflate as you inflate the metallic stent. What is their chemical or engineering background, I cannot tell you.
Okay, thank you, Dr. Toth. So that we have to move on for the sake of time, so that we may need to switch the gear a little bit. And Dr. Watanabe will talk about the stop depth to high bleeding risk subgroup analysis. Please.
On behalf of the stop depth investigators, and it's my great pleasure to make a presentation in this EBC 2019. And firstly, reviewing the stop depth trial, the stop depth 2 is a prospective, multi-center, open-label, randomized trial conducted in Japan. They're comparing 1 month versus 12 months of DPT after exclusive use of science with limited exclusion criteria. The randomization was made during the index hospitalization, and 1 month DAPT group stopped DAPT at 1 month and received clopidogrel monotherapy after that. And in the 12 month DAPT group, continued continue the DAPT with aspirin and clopidogrel up to 1 year. The primary analysis was made at 1 year for non-inferiority of the 1 month DAPT group. The primary endpoint was a composite of cardiovascular and breathing endpoint, and the 1 year incidence rate was 3.7% in 12 months DAPT arm and 2.4% in 1 month DAPT arm. So the not only non-inferiority but also the superiority was shown as for the primary endpoint. And as for the major secondary endpoint, about the cardiovascular endpoint, there was no significant difference between the two groups. And as for the breathing endpoint, the 1 month DAPT group was significantly lower incidence about the breathing endpoint. And in this TCT, we presented the post-hoc, the high bleeding risk patient analysis in this top-adapted trial. The newly proposed HBR criteria provided a standardization of HBR definition. The various criteria that are proposed, and these are the details of the HBR criteria. The patients are considered to be HBR if they have the 1 major or 2 minor criteria. But of course, the stop-adapted started before the HBR criteria, so we did not capture precise HBR criteria, so we required a modification of this criteria. So particularly, the malignancy was excluded from this criteria because of we did not capture the disease is active or not. And in the total 3,009 study population, about 35% of patients are classified into the HBR. And when we see the background, the backgrounds are well balanced between the two assigned DAPT group, both in a non-HBR and HBR group. This is the result of the primary outcome stratified by the HBR or non-HBR. The 1 year incidence rate was 6.0% in 12 months DAPT and 3.5% in 1 month DAPT in HBR stratum. Then 1 month DAPT trended to be lower incidence of the primary endpoint in HBR stratum. And as for this major secondary cardiovascular outcome, there was no significant difference between the two groups. And as for the breathing outcome, in HBR stratum, only 0.4% in 1 month DAPT arm in HBR stratum. There's no significant difference between the two groups in HBR stratum. So this is a summary of the HBR subgroup analysis. Then there's no significant interaction between the assigned adaptive group and the HBR subgroup. And it's noteworthy that only 0.4% are experiencing the breathing endpoint even in HBR stratum if we apply the 1 month DAPT group. That is comparable with the non-HBR patient. In addition, for this conference, we prepared the data of the bifurcation a little. And in the stop-adapted trial, we defined the bifurcation lesion in the presence of the side branch with the 2.2 millimeter or more in the diameter. And totally 801, 23.6% in lesion basis are counted as a bifurcation lesions in basis of the site reporting. And more than half of the bifurcation lesions are located in the proximal LAD and the diagonal. And the left main bifurcation was about 10%. Unfortunately, only less than 2% regions were treated with 2 stents, and most were treated in 1 stent strategy, and the KBT was performed only 30%. And when we look at the strategy by the location of the lesion, in left main bifurcation, the KBT was preferably conducted, but in other lesions, most patients received overlapping stenting without KBT. This is the result of the primary and secondary cardiovascular outcomes by the bifurcation strategy. There was no significant interaction about the effect of short duct. And when we see about the 2-stent procedure, there are very few patients having the 2-stent procedure. That we cannot say anything statistically, but the 9 patients with 2-stent strategy in 1 month DAPT arm had no primary and cardiovascular event at 1 year. And when we see the a single stent with KBT, the numerically 1 month DAPT group had more adverse event, but when we see the breakdown, the 1 month DAPT group included 3 more ischemic stroke by chance. Therefore, when we focus on the coronary adverse event, the number is not so different. Also, there are some important limitations. These are the post hoc and underpowered analysis, and the precise arc HBR definition could not be applied. And there's very few patients participated in this study with complex stenting for bifurcation. And extrapolation should be carefully considered because Japanese patients are known to have lower ischemic risk and higher bleeding risk compared with US or European population. Then in conclusion, the effect of the 1 month DAPT versus 12 months DAPT on the primary and major secondary endpoints were consistent in HBR patients and any bifurcation strategy without any significant interaction. The 1 month DAPT was associated with significant reduction of major bleeding without any increase of cardiovascular event in HBR patients. As for the bifurcation, in the study, very few patients with complex PCI for bifurcation participated, but there was no sign 1 month DAPT significantly increases the coronary adverse events. Thank you for your attention.
Thank you, Dr. Watanabe, for the very elegant and important, issue. And it's very interesting to see that from yesterday to today, we've seen the malapose strut, high voice stress, thrombosis, platelet activation, but in this study, 1 month DAPT is enough, even leaving all those strut alone. So that there should be some gaps between our, theory and patient outcome. So that that's what we need to work harder for. So any questions, Doctor?
Do you know, I know that in Japan, most of the complex procedures are done on the basis of imaging guidance.
Yes, imaging.
Do you know how many of these interventions have been done by imaging? Because we think that, imaging may reduce imperfections, and so this may be, an explanation.
Yeah, maybe yes. In the main trial, we showed the data. As you know, about 100% patients, PCI patients, they received PCI with IBIOSS or OCT. So, and then in this bifurcation PCI, also almost all patients receiving the imaging guidance.
This is very important.
Sure. So I understand.
So one more question: what drugs have been used for DAPT, and what drug was skipped in the group with the short DAPT? Clopidogrel, or patients were left on aspirin, or how was it?
Okay, and first 1 month the DAPT was consisted with aspirin and any P12 okay, so clopidogrel or prasugrel okay, but in the protocol beyond the 1 month we choose the clopidogrel most likely.
Okay, so most of the patients in the short DAPT group were on clopidogrel?
Yes, clopidogrel, beyond 1 month.
Dr. Watanabe, have you some explanation on your very, very low rate of bleeding, your bleeding rate in the HBR group, 0.41%?
0.4, yeah.
Yes, it's very, very low. And do you have some explanation in your very
I think it is the effect of the aspirin, maybe. So to reduce the aspirin, so maybe so the content of the reduction of the bleeding is mainly because of the reduction of the gastrointestinal bleeding. So as you know, that the aspirin caused the gastric ulcer or other GI bleeding. So if you skip the aspirin, then maybe GI bleeding will be reduced. Okay.
I understand. Thank you. Thank you very much. Another question? No. We can move. And I invite. Thank you again. And we invite Dr. Burzotta, pre-kissing of Medina 111 bifurcation lesions.
So, good morning. Okay, so when we have complex lesions, we know that complications are more common. This is the important Korean data showing that as soon as Medina complexity increase, we have a longer procedure with more complications and more adverse events in the long-term outcome. So, and we know that we may look on the best technique for stent implantation, but most of the work when anatomy is complex is performed during the predilation process. So if we look at side branch predilation impact, we have the data with, from a large Korean study registry showing that there is a signal for worse outcome if we predilate the side branch. And we have only one randomized trial performed once again by Spanish group. Manuel Pan was heading it. And they have been so brave to randomize patients with complex bifurcations to predilation or not. And what they found is the fact that the procedure is facilitated by predilation, having after crossover stenting more patients with 3-3 flow. So there are conflicting evidence and no final arguments about the fact that side branch should be routinely dilated in difficult anatomies. When we, in my lab, when we have lesions like that, instead of working, deciding since the beginning what should be the stenting strategy here, since we like very much the provisional approach, what we try to do is to perform the provisional flow, but most of the work is done according to our perception during the predilation. So if we perform OCT in this situation, you see that really at the level of the bifurcations you have a lot of plaque, which is mainly on the counterpart of the carina. So what we used to do is to advance the two guide wires, then to place over there two balloons which are a little bit undersized and not too aggressive, and then we perform a predilation in one branch, in the other branch, and we finish with this pre-kissing technique. Why to do this? Because we think that the problem in this kind of lesion is the fact that we have a lot of plaque in the area of bifurcation. And if we end up with the dilation in one of the sides, we will perform carina and plaque shift in the other side. If we end up with a kissing balloon inflation, what we will have is to displace the plaque on the opposite of the carena. And so if we come back in this case after pre-kissing, you see this is the aspect. So now it is completely different. I mean, the approach to this bifurcation. And if you perform OCT, you find very well that, the carina is over there, is in the middle, and you have more space for your provisional technique. So what we did was to perform the drug-eluting stent implantation to what was our main vessel, which was the descending posterior. Then we implanted the stent. Then this is the result. You see that there is a TME3 flow with a lot of space inside the side branch ostium. Then we performed the POT, and this is the result after POT. Then we performed the side branch rewiring according to the pullback technique. You see that we checked in this case, by angiography. It was very evident that we were into the distality of the side branch. We performed the kissing balloon inflation according to non-compliant balloon with not too much protrusion into the distality. Since there was more lesion proximal, we optimized it with another stent, and this is the result. And this is the OCT showing that, the lesion has been really transformed in something which is very suitable for the provisional. So our experience with pre-kissing has been reviewed out of our consecutive bifurcation. So we selected those with complex as, according to Medina, all the one with involvement inside the bifurcation with at least 2 points. And we selected more than 500 patients with these lesions. 66 were treated by pre-kissing, and we had the control group. Since there was the possibility to have a selection bias in favor of worse patients exposed to pre-kissing, we performed a propensity matched control group of 126. These are the baseline characteristics. You see that the lesions are really complex. You may see that Medina 1-1 lesions were with pre-kissing 85%, that most of the lesions were long. There were acute angulation, and there were also some patients with impaired TIMI flow at the beginning. There were no differences between the pre-kissing and the propensity matched control group. And when you look at the steps for provisional, we assessed the incidence of side branch less than TIMI3 flow and was 6 against 13. Regarding the need of guide wires different from workhorse was 3 against 9.5, and failure of side branch rewiring and side branch dilation didn't occur with the pre-kissing technique. And any side branch trouble, which is the composite of all these problems you may have during your procedure, was highly statistically significant in favor of pre-kissing technique. And the need of second stent was not significantly increased. So in the multivariate analysis, the only independent predictors of side branch trouble were no pre-kissing, side branch TIMI flow at the beginning less than 3, and side branch lesion more than 5, and Medina class 1. So all of this is consistent. And looking at what happens during our procedure, we have been able to show that there were TIMI3 flow which were similar at the beginning. After the main vessel stenting, there was more rate of TIMI3 flow in the group of pre-kissing, and at the end there was a trend which was not statistically significant. And this paper, I mean, for more information can be found in internet because it has been recently published. Thank you for your attention.
Thank you, Dr. Burzotta. Any question in the audience or the panel?
Francesco, when you perform the first kissing, in which proportion of patients you avoid the second kissing after main vessel stenting?
Sometimes it happens. Honestly, it happens sometimes. I didn't review, so I don't want to give you a figure. But for example, in the left main, we use to end up with a final kissing inflation. In lesions which are like that, a little bit more distal, sometimes we do not perform at the end if there is perfect flow inside the side branch.
Thank you. Another question?
Do you think doing the first kissing before in a provisional approach decreases your chances of good distal rewiring for a final kiss? If you do because the dissection will be close to the carina, so you are less likely to cross distally for the final kiss.
Anytime we decide whether to perform or not side branch dilation, this is the main issue. If we perform any intervention, we start having the risk of dissection. However, when we do this, we usually do in the cases in which we are doing predilation. So we do not do it routinely. We do it anytime we feel that we should predilate the side branch due to the higher risk. So we do, instead of side branch isolated predilation. And the second, we try to use a little bit undersized balloon in the both branch. Let's say less than 0.25 as compared to the stent we would implant in the case of stenting.
And I wanted to say whenever in a bifurcation it is close to a CTO, like the bifurcation, the CTO is just proximal to a major bifurcation, or if the CTO is just at the site of the bifurcation. In those situations, if you are not using imaging like the case we saw yesterday, sometimes your wire goes subintimal in front of the side branch. And then in those situations, before stenting the main branch, if we do a kissing balloon between the side branch and the main branch, it may prevent sudden occlusion of the side branch after stenting the main branch. So that maybe is one.
So I think that as the more complex is the lesion around the exact polygon or confluence, the more may be the benefit of this technique, in my mind.
A question.
Thank you so much. Okay, thank you. I think the most concern of the pre-dilatation with kissing balloon may cause the dissection of side branch, which may interfere the rewiring. Do you think can we treat this bifurcation lesion just put a gel balloon in the side branch and implanting the main vessel stent and perform a port for the main vessel and reclose, rewire the side branch and do the final kissing? Maybe a safer way, make it.
The gel balloon protection is one of the techniques you may use to reduce the risk of this kind of complication, side branch occlusion, so it can be considered. But what I feel is the fact that if we pre-dilate properly the bifurcation before deciding the stenting technique, we have the benefit to, first of all, assess the compliance of the plaque. So if there is the need of shock wave or, more aggressive dilation, you find it at this earlier stage of your procedure. For sure, I'm not suggesting using it in lesions which are not very complex and very tight. So this is something that can be applied and considered just when you have really lot of plaque around and you are very open to implant 2 stents. In the case you have dissection in one of the 2 sides, you may decide to perform inverted provisional and implanting the stent, the first stent toward the branch which has been dissected. So this is, a possible way to postpone the decision regarding the stenting technique after having pre-dilated properly the lesion, which is something that when you have a lot of plaque makes sense.
Thank you, Dr. Burzotta. Thank you very much.
This is the final talk of the keynote lecture, employing a visible heart methodology to uniquely investigate bifurcation stenting. The Dr. Iaizzo, please. Iaizzo, please.
Well, good morning, everybody. It's a privilege to be here. I'd like to thank the organizers for the kind invitation to be here. It's always exciting for me to talk about the Visible Heart Project and the Atlas of Human Cardiac Anatomy. So I'm going to start with some acknowledgements before I begin, because it's a large laboratory, the Visible Heart Lab. It's myself, Dr. Iaizzo, assistant professor. We actually have a staff, couple scientists, full-time programmer, lab coordinators. Right now there's 8 PhD students, a couple master's students, and a cardiology fellow. So this is really a team sport to perform these visible heart studies. But historically, our lab is located in the basement of the Mayo Building on the campus of the University of Minnesota. And it's the site where Earl Bakken, the founder of Medtronic, brought the first wearable pacemaker and did a preclinical trial in 1958. So really rich history of this labs. The rest of the story is that day, after 4 or 5 hours of testing, the wearable pacemaker was moved off this animal and placed on a young child up in the intensive care unit. So a very different era for medical device testing and trials. So our lab has a lot of different functions, but we also have a heart library, which is kind of a unique library. There's over 500 perfusion-fixed specimens in this library. These are hearts not deemed viable for transplant that we can get to our laboratory fresh within 4 to 10 hours. We'll fix them under a pressure load to hold an end-diastolic shape. And then afterwards, we can put cameras in them, view all the anatomy. We can do MRI scans. We've done over 350 MRI scans of these fixed specimens. We can do CTs as well. And then they're a library for research. So again, these are gifted to the lab. So then we gift this to everybody else. So we call it a library. That means any student, any academician, anybody from any company has the privilege to come and use these specimens. The Visible Heart project, though, is where we reanimate hearts. This project started in 1996. We've had industry partner, Medtronic, that has funded the project since '97. It allows us to really look at functional anatomy inside the heart. So it's a huge educational component, but you can evaluate different therapeutic approaches, in this case, bifurcation stenting, different approaches there, and then you can really closely document the device-tissue interface. And again, afterwards, all the hearts are then fixed and then added to the library. So on a routine basis, we're using animal hearts. Typically, we'll use a pig heart. So we'll reanimate these swine hearts. We've done over 1,900. We've done mini pig, ovine, canine. You pick the specimen for the anatomy you want to study. In this case, showing here, this is a spectromagnetics laser. We're doing a lead extraction here. This was a canine heart with chronically implanted leads. So our lab does everything from leads to ablations to valves to the stenting. So any cardiac device, we've tested thousands in the lab. This is the lab setup. We can do multimodal imaging in the lab. We can do echo. We can do the endoscopes. We have an OCT system. We can do ultrasound studies in there. And a typical day, you know, this is the setup. We'll bring the equipment in here. The heart will be beating outside the body. We can bring in our various equipment. And these are electrically activated specimens still, so they're all functional. We can record electrical activity. You can paste these specimens. So it's a really unique opportunity to study a lot of unique physiology and device tissue interfaces. So we've also, beyond doing the reanimated animal hearts, we've had the privilege to reanimate 85 human hearts since 2000. That means there's an organ donor. The heart's not deemed viable for transplant. We can get it to the lab within 4 to 6 hours, just like a transplantation time window. It's intact, which means they didn't do a lung transplant, then removed the left atrium. The right atrium's intact with liver team. Didn't have to take the whole IVC or the right atrium. So it's rare. And then it has to have a reasonable ejection fraction. If we've tried these with low ejection fractions, they won't function. So for the first 2 hours, we dedicate the lab to collect functional anatomy inside these hearts, really to share all this unique anatomy of all these hearts with everybody. And we'll do that on our free access website. Then after that, grad students who are doing work on swine hearts then can do it on human hearts, making their work translational. And after that, we have a priority list of different device studies we'd like to perform. Again, we're trying to maximize what we can get out of each of these reanimated hearts. They'll last for some 5 to 8 hours before the function goes down, and then we'll fix them and put them in the library. We've also had the unique opportunity to do heart-lung blocks. So in a way, not only do we have a visible heart, but we have a visible lung. And you can see in this case, I've got a endoscope down the pulmonary veins. I'm retracting the scope back, and you can see on the x-ray below the border between the lung and the heart. And as I pull that back, you can see all this amazing vasculature within the lung. Again, these lungs are on a ventilator, so you can really study all this functional anatomy. Of course, if you're looking at devices to do ablations of the pulmonary veins, having the lungs intact like this is really beneficial and really gives you a lot of insight into varied anatomy. Just like everybody's got a unique thumbprint, everybody in this room knows everybody's got a quite unique heart and lung and anatomies. So having this library of this is really critical for understanding a lot of these devices. Again, this is not new stuff. Dr. Newell Martin, who's a British physiologist, discussed this in the 1880s. Dr. Langendorf, who's a German physiologist, discussed this in the 1890s. The difference is we don't use blood, we use a clear perfusate, and we have the coolest toys to play with now with all the imaging and different capabilities. And again, this shows another one of those heart-lung blocks where the valves are still functional. You can see the mitral valve on the upper left, from the left atrium, from upper right, from below, from a camera in the left ventricle. And so we've done a lot of these specimens. So in the end, when we get these human hearts, we're trying to maximize the knowledge we can gain from them. So we'll take all the functional images, we'll do echoes on them, we'll then actually fix these hearts afterwards. We can make computational models. We're down to about 200 to 300 micron resolutions of these hearts. We can do all the electricals. So we're doing functional anatomy, 3D echoes, fluoro, PV loops, electrical mapping. Then we'll fix the hearts. Afterwards, we can do more MRIs and CTs. We can do diffuser tensor MRI to look at fiber orientation. And then we're collaborating with the group in Manchester, Helena Dobozinski's group. Now they're doing micro CT and reconstructing the whole conduction system within these specimens. We're sharing all this really rich data with the supercomputer group here in Barcelona. And they're doing computational modeling of all this anatomy and functional aspects. So the last couple of hearts we did, one of the interesting things we did his pacing, as you can see in the upper left. This was recently published, where we can move our pacing lead around, do different his pacing, look at thresholds, and study that in different real human anatomies. And on the upper right, you can see an evolute delivery here. And this video was, again, published, and that's kind of the agreement that we're going to publish these for everybody to learn from. In that case, there was malposition of the placement of the TAVR device, and then we recaptured and repositioned. So we've been doing the bifurcation studies for a number of years. I think Dr. Louvard and Burzotta were some of the first couple individuals from the EBC, the experts. And this is the beauty of the lab, is we have these world-renowned experts coming to the lab and performing these procedures. The difference in imaging, though, is I have a camera inside, and I'm watching the whole procedure in real time. And we can do also the compared multimodal imaging. So it really allows you to better study all the different steps of these. And again, this is done in swine hearts. You can see a nice provisional technique performed here. And I'll say that Dr. Burzotta says the value of doing this in animal hearts is that they have the native carina, and then you can design your procedure to try to regain that, because you can see what it should look like. We've added OCT. Here you can see Dr. Stankovic, who's here in the room, came to the Visible Heart lab performing different procedures as well. So we've actually been able to document optimized procedures here, and you can see all the difficulties as well. And then these, again, are being shared with others to help everybody better understand and learn these protocols. So I think they'll be presenting some of this later on, but we also have some of this online available. We have a site, the Atlas of Human Cardiac Anatomy, and then Medtronic also has a site for bifurcation that people can go online for free and download these images. One of the interesting things afterwards, we'll take these whole hearts where all these different procedures are performed. We'll perfusion fix them and bring the whole heart into the micro CT. So we're looking at all these micro CTs post-procedure performed by the experts as optimal or maybe even suboptimal procedures. And you can kind of then 3D print these and then have really nice chance to have mixed realities to study this and understand the different techniques. You know, on rare occasions, we've been able to do the human hearts. This case, though, this is something we have to think about, and an opportunity for everybody here in the room to think about how we could optimize utilizing this heart library. In this case, I'm performing a bifurcation, a left main bifurcation. That was human heart 198. And basically, I'm just looking at the steps or the guidances or procedural recommendations from the EBC. I'm kind of looking at my handbooks. I've seen these performed beautifully by experts, and then I'm trying to mimic what they're doing. So this kind of see one, do one kind of approach. And then I'm going through the various steps, trying to visualize all this. We can use the fluoro for this. We didn't have OCT available when we were doing these, but this in the future is something we would have available. So again, now we have these large range of varied human anatomies. It's a really unique opportunity then for us to go in and perform these procedures and really try to evaluate the outcomes of that, and in both diseased and undiseased vessels, because some of these hearts are fairly healthy. But we do have those with heavy disease where the osseas are less than a millimeter for the right or left mains. So you can kind of see the final outcome there of the procedure that I performed after watching the experts. We've also had the unique opportunity recently to reanimate some human hearts, and then in this past year, we've had 2 opportunities where late in the day, after the heart's not functioning as well, but we've really optimized all the educational aspects, some other device delivery aspects here. Then we've gone ahead and done left main bifurcation stenting, and you know, afterwards again took that whole human heart, fixed it, brought it to our micro CT scanner, and then you can see on the lower left there, this is the resultant procedure. So, you know, this is probably a way to look at maybe suboptimal outcomes, because you have me as an operator. I'm a physiologist by training. I'm not an interventional cardiologist. But still, we can learn from these things, I think, in a very unique way. So it just kind of goes through, you can see the steps of the procedure. And this is another one here. Let's see if I can, whoop, there we go. Another one that we recently performed, which had a little bit shorter left main. And then we're able to, again, watch the whole procedure, do the fluoros. In the future, we can do the OCTs. And then afterwards, this specimen is a permanent specimen in our library. So we can go in and, you know, now we can go back and do an OCT on the result of this procedure versus doing it each step of the procedure, which would optimally like to do. And again, I'd like to point out that in this case, using the visible heart approach, there's really no stress involved, because basically you have as much time as you want. You can use OCT as much as you want, because there's no time window. You can give as much contrast as you want, and really create and optimize the educational materials that you can get out of each of these specimens. You can kind of see the final result there as I'm going in, and we're doing some of the last redilations there and the final pot. And like I said, Tommy Valenzuela, one of the PhD students, cut these for me last week so I could show at the meeting here. So again, we have all these MRI scans. We can look at this whole library of over 500 perfusion fixed hearts. We look for bifurcation lesions down the various anatomies, circumflex, LAD, right side, but then we can do also the left main bifurcation. So I think this is a really rich opportunity for the European Bifurcation Club to document what different procedures they think would be really helpful to utilize this to study different procedure performances. We can take all that and then outside at the Medtronic booth where, again, we can put that in virtual reality, and then you can actually hold the 3D stents of the actual procedures. So these are, again, micro CTs of hearts in which different bifurcation procedures have been performed, and then you can drive through and visualize all that. So again, a lot of this is available on the Atlas of Human Cardiac Anatomy. There's over 5,000 videos and images on this. There's a huge heart database, so we document what we know relative to disease states. We have the MRI scans of these. We have a device tutorial on stenting that we're always trying to improve. And so if anybody here has any advice on how we can optimize this, we'd be more than happy to hear. And last year alone, we had over 500,000 people go to the site and open up files, and that's what we called as a user. So we're very excited about this outreach education opportunity. So just to kind of summarize, the Visible Heart Laboratory has a lot of different abilities. We have a heart library, but we also reanimate these hearts on a routine basis, and this allows you to really study the device tissue interface, and you can do that with multiple modalities, and you can perform optimal or suboptimal on purpose, or if you have an experienced user like me, without worrying about it, right? Because you don't have to worry about procedure times, contrast injections, and or really the outcomes, because these are real fixed human specimens. And so we perform many bifurcation stenting procedures. We've done the computational modelings, and those can be used for the 3D printing and the VR scenes. And I think it's really this studying these mixed realities that really is educational for others. And again, we've shared these a lot on the Atlas website. So with that, I thank everybody for their attention and happy to answer any questions.
Thank you. Thank you for the this is a very excellent praise. It is like a dreamland. So everyone would like to work there. Are there any comment from panelists?
Yes.
Thanks for the great presentation. Pigs have beautifully clean coronary arteries from the videos that I saw. Are there any animal models that have a burden of atherosclerosis to sort of more mimic what we do in patients?
Yeah, you can get some of the older sheep. They'll start to have some coronary artery disease, but there are also groups a company called Recombinetics, where they're trying to make transgenic animals to express coronary artery disease. I think they're making some good progress, and that is a porcine transgenic model. So in the future, we can look at that, but we can also try to emulate different disease states by, banding the vessels, or, actually a quick trick we tried is putting super glue on them. And actually, it's kind of a funny, nice picture to look at, and then you can expand that again. But again, this is where the rich value, I think, of this heart library, where we have real pathologies, and the perfusion fixation with the 10% formalin really doesn't alter the properties of the vessels dramatically. All right.
So I think now we can have a coffee break for 20 minutes.